This panel is on price transparency, and it touches on a lot of things we've talked about earlier, especially during the debate, this idea of how to make patients better consumers of healthcare. And that's something that's very difficult to do if the consumer doesn't know the price of the product, which is especially true in America. You have a system where the lack of transparency is actually built into many contracts, as most of you know. And you get these perverse situations where in a city like Miami, the cost of a mammogram is anywhere from $45 to $400. In New York, the cost of a back scan is anywhere from $70 to 10 times that amount. So how can patients become better consumers if they don't know the price? You each have a unique perspective. Tell me what you've seen from your perspective, the good, the bad, and the ugly of price transparency, and we'll just go in order. We'll start with you, Harold.
Sure. Well, I think price transparency is a critical element to being able to reform healthcare. If people don't know what the cost of services is, how can they choose wisely? And that's true for physicians too, because physicians have trouble advising patients where to go when they don't know what things cost either. But my concern is I think that price transparency is necessary but not sufficient, and that if you just do price transparency, which is, there's a lot of focus, just somehow price transparency is going to transform the healthcare system. I think that price transparency alone could actually be a bad thing. And the reason is because it's really, there's a sort of a three-legged stool, and price transparency is just one leg of the stool. The second key thing that has to be there is to actually pay for healthcare in a different way. The problem is that if consumers, what's the price that they're actually getting transparent? If it's the price of individual small services, they may end up thinking that the price on those services is lower, but end up getting more of those services, and the total cost is really what should matter to them. And today, it's very difficult for people to find out what the total cost of their care is going to be. That they may pay for the hospitalization, they may pay separately for all the physicians, they may pay for a readmission, they may pay for post-acute care. All those things get paid separately. Moreover, and I think even more problematically, is if something bad happens to the patient, and that has to be taken care of, they pay more for that too. And that's because we pay for healthcare in this fragmented fashion. We pay for everything separately. And what we really need to have to complement price transparency is payment reform. We need to be paying for total packages of care to patients. And just like every other industry but healthcare, there has to be a warranty on care, so that whenever healthcare providers provide care and there is a problem that arises that they could have prevented, they should treat that problem at no charge to the patient. And if you have that total package, then it's a whole lot easier to evaluate and to compare providers with each other. But then the third leg of the stool is that typically patients don't pay anything near what the total price is. And we've spent a lot of time talking about what's the price of an MRI or what's the price of a mammogram. But a lot of the money in healthcare is going to much more expensive services. And today, patients really don't pay anything near what that cost is. So if you're looking to get your knee replaced and there's 3 places in town that do it, one will do it at $20,000, one will do it at $25,000, and one will do it at $30,000. From the patient's perspective, those are all going to probably cost them exactly the same amount. So I'll take the $30,000 option, thank you very much, because that sounds to me like it's going to be a better thing. I'd rather have the Ferrari than the Ford any day. And that's because we are obsessed in healthcare with co-pays, co-insurance, and high deductibles, which actually can discourage people from getting the lower cost services that they need and then make them indifferent to the price differences between the more expensive services. So we really need to have patients paying the last dollar of care, not just the first dollar of care. And we've seen that happen in California with CalPERS, which found that it was paying between $15,000 and $110,000 for knee replacements. And when they said, we think you can get a good quality knee replacement for $30,000 or less, we'll pay $30,000. And if you want to take out a second mortgage on your house and go to the $110,000 place, be our guest. Guess what happened? Consumers switched, and the expensive healthcare providers reduced their cost. So you have to have all three legs of that stool. You have to have price transparency, you have to have payment reform, pay differently for total packages of care with warranties, and you have to have benefit design changes so that the consumers are actually sensitive to those price differences for the most expensive kinds of care.
Right, okay. Leah, you have an interesting perspective. You rate hospitals. Does price come into it when you rate them?
No, it does not, but we are very supportive of price transparency and think that it is a very powerful and important movement in healthcare. And I will tell you why. First of all, to step back a bit, my organization is called the Leapfrog Group. We're nonprofit. We represent employer purchasers of health benefits. So typically large companies, sometimes large unions that are directly purchasing a lot of healthcare benefits. Since we were formed back and actually I should mention, Lily is one of our founding members, so they're, I know, a part of this conference as well. We, from the beginning, when we started in 2000, the executives who founded Leapfrog were just starting out with the simple premise that their employees ought to be able to shop among hospital care the way they shop for other products and services, including the products and services that these same executives were producing in their own companies. So one of our founders, big example, was GM, and they knew that their own cars were subjected to a high level of market transparency on both pricing and quality from a variety of raters, and that they didn't understand why they're spending more in health benefits than they earned in profits, and yet their employees have really almost nothing to go on to choose among hospitals. So they founded Leapfrog as a way to bring the leverage of hundreds of purchasers together to ask hospitals to give us this information that we're looking for this shopping. So for employees to be able to compare among safety and quality in different hospitals. And so fast forward 15 years, here we are. We now have over 1,500 hospitals voluntarily providing information to Leapfrog that is publicly available at no cost to anyone. To take a look at how hospitals are doing on safety. And we also rate now hospitals on their safety. We give them a letter grade, A, B, C, D, or F, on how safe they are for patients. So we are in now this field that is now a much wider field, which is good. When we started out, it was considered crazy for these employers and anyone else to try to issue a report card on hospital performance. Now, of course, it's much more standard. So here's what happened also in the course of this change, and that is that we've had the advent of high deductible health plans or consumer-driven health plans. It's been talked about today quite a bit. It is a major movement, as significant in my mind as the Affordable Care Act. When we look at the numbers, 1 in 5 American workers is now covered by a high deductible health plan. And half of all workers in companies with more than 5,000 employees, so those Fortune 1,000 companies, half of those workers are offered one. So this is a tsunami that's, we're not at the crest of it, it's coming. And there's a lot of interest as a result of that in pricing, because when people all of a sudden have to worry about how much that MRI is going to cost, they're asking the question and they want that information. So that for Leapfrog has been a positive, because though we're focused on quality and safety are the second question, always asked after price. You know, none of us walk into a car dealership and say, okay, I have $20,000, give me a car, period. They'll say, what do you have for around $20,000? That's my price point. That is my first price. That is really my first thought when I go into buying something like that. But then the second question is, what do I get for that? What are the features? What are the benefits? And how do I weigh them? That is exactly what's happening now that we're seeing in healthcare, and that's why we think, from Leapfrog's perspective, in this movement of providing quality and safety and transparency to the American public, that the price transparency may be the gateway to a far more informed and active American consumer.
Okay. Stephen, you are the Chief Medical Officer of one of the largest customer-owned health insurers in America. I'm told by many people over lunch that insurers are the villains here, that they are part of the problem. Defend yourself.
Well, I actually believe that we're an important part of the solution, and we all have to work together. That was brought out this morning. You know, all stakeholders in the healthcare field, the consumer, the payer, the provider, and the people that supply the pharmaceuticals and devices, we're all in this together, and we're going to be stronger together. And that's a lot of, in the payment reform space, one of the things I like about that is it does start to align you. And once you're aligned to similar incentives, you have a lot of traction. I think you're going to see a lot of convergence too on not only this panel but throughout the day, that what Harold said, that cost is necessary but not sufficient. This is healthcare. This isn't simply price. This isn't a commodity. This is our lives. And so we are very committed to value transparency, and that brings in quality and cost. And we're also not just interested in talking about it anymore. At HCSC, we've gotten off the dime, and we're actually doing. So we have a thing that's available called the Provider Finder. It actually brings in quality measures, and next year it'll include Leapfrog. So many different quality measures as well as cost measures that is available on 400,000 healthcare professionals and 21,000 facilities. And it's not just about what the overall cost is there. It's about what your out-of-pocket cost is. So if you have a policy, you can find out what your out-of-pocket cost is as well as the overall cost. That's really important as a consumer, because as we expect consumers to increasingly behave like consumers in healthcare, we have to give them the tools to be consumers. They have to know quality and cost. And so we're committed to doing both of those. And that's why I want to make the point that we're done talking. We're in the process of doing. It will be iterative. We will continue to add things like Leapfrog. We will continue to add capabilities. We're already web and mobile. We want to make this available, increasingly broadly. And so millions of people can do that today and start making good consumer choices. And that's not just to blow our own horn. That's something you see in the industry. People are moving to this transparency, and that is going to transform the insurance industry. First of all, when you think about insurance, I bet everybody in this room has it. So if it's a bad product, well, how come everybody wants it? So it's a necessary thing. The same reason you have car insurance. We can usually afford the premium, but we really can't afford the cost of our cars totaled. And so in healthcare, we have insurance because if you are unlucky enough to get sick and need serious medical help, you're going to need help. And so we pool together. That's what insurance does. It allows us to share risk. And we do that as a society. And so I think that transparency will help us share that risk in a more rational way and help us build towards reimbursement reform.
Okay. Dave, you work with providers. Can you give me their perspective?
Sure. Actually, for Relay, we're sort of in a unique spot. We work with probably 60% of all of the U.S. hospitals. We provide their revenue cycle solutions. We probably are with 90% of all of the U.S. payers. And so we're sort of sitting in the middle, and we watch two large entities that quite candidly just don't trust one another. And they work by exception based, and everything is why it will not work versus how do we make it work. Now, the beauty is we're starting to see that change. I mean, Steve and I were talking earlier, and we're really seeing, the entire industry is going through a whole transformation. We talk about value-based reimbursement. We talk about changing the way patients, but really what's happening is consumers getting involved. I mean, Leah brought it up earlier, and for the first time in my career, the consumer, we the individual patient, member, whichever term we want to use, is finally being engaged in healthcare. And that is, we now have the ability to make the decision. Not the employer, not the payer, not the hospital, but we. And it's very similar to banking. A long time ago, 10, 15 years ago in the banking industry, most of us made a decision on our bank based on where our direct deposit was told it would go by our employer. Not what we decided, but where our employer said they did their banking. Today, our banking is decided by us, and the services that we receive by what fees that we want to pay. So from a Relay McKesson point of view, what we're really trying to do is help facilitate the communications and bring people together and move away from pricing transparency. I mean, Harold, Leah, Steve all brought it up. Without quality and different segmentations of quality, pricing's immaterial. It's like watching the QVC network. Everything is, and the retail price is, but the QVC price is, and it's crazy. And so until I know what I'm buying and what I'm receiving, it doesn't make a difference.
Right. Okay, we're going to get back to pricing and quality and how they work together. But first, I want to ask Harold a question. Everyone seems to be in favor of price transparency, yet somehow we get these contracts with these clauses that say you cannot tell people what the price of these procedures are. Someone's a villain here. Who's the villain? Who is holding up the works here on price transparency?
Well, that arises because we are obsessed with the price and we're not obsessed with anything else. And so everybody focuses on what's the discount on the price. And everybody wants to get the best discount, and oh, by the way, it's got to be secret. And so every employer thinks that they're getting a better deal than every other employer is on the price, even though they may not be. So it's all secret. And what we have today is rampant price discrimination. So one person may end up paying 4 to 5 times as much as somebody else does, simply based on what kind of health insurance they have. That's crazy. I mean, there's no other market. You don't go into the grocery store, and when you go to the checkout line, they say, tell me who you work for, and then I'll tell you how much your bread costs. They say, here's the price, right? And it should be the same way everywhere else. But right now, the focus is solely on price and not based on that overall quality outcome. So in fact, if you could actually keep patients healthier, if you could reduce the safety problems that occur, and you could do that at a lower total cost, then it actually may cost you more for the individual service to do that, but the total package costs less. But we don't have that because we don't pay that way. So everybody's focused on trying to get that maximum discount, but don't tell anybody else because we've got a better deal.
Right. Leah, your Leapfrog Group, you take into account quality, but not price, you said. I mean, why is price not part of your evaluation?
Well, to Harold's point, prices are insane. There are no prices. There's a lot of different negotiated rates. So we're a national organization. We report nationally. We compare hospitals nationally. There's no one price we can compare them on. There's 100 different prices. Most are secret. So from our point of view, the pricing is not something we can compare them on. We could compare them on other things because in healthcare there's like 100 different ways to describe. There's a mythology that there's 100 different words for snow in Alaska, which is not true. But in healthcare there's 100 different words for price or quality or it's price, cost, charges. I mean, there's a billion different ways of describing it, which is just emblematic of the fact that there is no one price.
And even if you can find out what the one price is, it actually is a meaningless number.
Right,
because
exactly,
it's usually, it's the charge master.
Right.
So to take Leah's example earlier, when you go in to buy a car, they don't hand you the parts list and say, here's the price of all the parts of the car, and then you say, well, gee, that engine sounds really good, I mean, you've got a V8 supercharged engine at a lower cost than anybody else. I'm going to take that, but we'll tell you what the overall bill is at the end. Well, gee, how'd that car end up coming out more expensive? Well, it's because whenever we put all that other stuff in there. That's not how people buy cars. It's not how they buy anything else, but that's how we end up having healthcare. Okay. So it would be meaningless to put out the price number for any individual service without knowing what the total package is.
Well, and I would add to that and the question in the poll, the fundamental flaw with your question, which is a cute question, but will price transparency negatively impact the care of patients who make their decisions based on price rather than quality? There are no such patients. I'm sorry, there are no such patients. Is there anyone in this room who would ever say, I'm going to pick a hospital for my child to go to the emergency room based entirely on how much that visit will cost? And I don't care how good they are.
But isn't this part of...
Hey, wait, I was waiting for a show of hands. Do a poll on that. I mean,
Thank
you
you.
would.
I mean,
Okay, all right.
I mean, isn't that part of what's happening now, though, with more of the costs being pushed onto patients? The idea is that they will start making choices based on price.
I mean, we all make some very tough decisions and calls in our life based on price, but we always consider quality, and especially for something like healthcare, which is so important. We're going to be interested. We're going to want to make sure we get the best care at the best price. But pricing does introduce a new level of decision making for the public, and I think it's important. We have to have the power of the consumer as a decision maker in the healthcare system. That's been a missing element.
So sort of two things here. Number one, I'm going to disappoint everybody. There's not a villain here. You've asked a couple of times. There was no villain that designed this system to somehow take advantage of everyone. The system arose sort of organically and not by design. And so it is what it is. And so one of the things, is let's get away from trying to figure out who's at fault and who's the villain, and start figuring out how we solve our problems in ways that are practical. How do we get to a aligned reimbursement model that will work for all the major stakeholders and most of all the consumers? How do we do quality that is not only good at a population level, but at that granular level of procedure and provider? And that's something, again, that we're really committed to. Right now, there's discussions going on between AHIP, American Health Insurance Plans, CMS, National Quality Forum, and major provider groups to look at how we do the 3 R's of quality. Reduce the variability in those measures, which drives everybody crazy, right? When Blue Cross has one measure of quality and Leapfrog has another and somebody else has another, that drives the providers crazy. So reduce the variability. Number 2, refine the ones that we have to make them easier to report on and collect. And number 3, make them clinically relevant. So to me, those are the 3 R's of quality. We're committed to working with all the different quality groups and developing quality measures that are not only good across populations, but are really good when you want to know what is the value, not just the quality or the price, but the value of that knee replacement I'm going to get given my choices. Providing consumers with that kind of information, that kind of transparency to make those decisions is what we all should be committed to. And I know that I am personally, and we are as a company.
So I agree with you that this system has risen organically, but I think from a patient's perspective, it sure feels like there must be a villain somewhere in here. When you call a hospital and ask for the price of a procedure and you can't get a straight answer, someone is sort of pulling the curtain in front of you so that you're not seeing this information. So okay, we don't have to assign blame, but tell me, how do we make this information more actionable for patients?
Sure. I think you make it relevant to the business interests of the people involved. Those who provide care, those who pay for care, that includes both insurance companies and consumers, those who provide the materials for care. And I think it gets back to something that Harold was talking about earlier, and that is, how do we transform a reimbursement model? And that's going to be a challenge. You have 1/6 of the nation's economy, more than 1/6, wrapped up in a series of business operations that are interdependent and rooted in kind of world one. Now we're trying to get towards world two of a aligned reimbursement model. Making that transition is easy to talk about and really tough to do, but we can do it. These are not insolvable problems. We're not coming up with another form of physics. We are coming up with solutions to problems. It's going to be iterative. And I think that was one of the things in the debate this morning on the Affordable Care Act that, the premise issue. It's not really, is it a success or a failure? Is it a start? The Affordable Care Act is a catalyst to starting a process of health reform. If anybody tells you that they have the plan, I know the answers on how to fix the healthcare system, and here's the playbook, you can leave. They're blowing smoke. Nobody knows how to do that. But we can iteratively build. And one of the things that we like to say is the future is now, or the future is here, it's just not evenly distributed. That comes from William Gibson, a book called Neuromancer in 1984. He also coined the term cyberspace. And he said that the future is here, it's just unevenly distributed. The answers are out there, and we're seeing that in our markets. And it's not one answer, but it's what is that portfolio of answers that we can bring in and learn from what's going on in the marketplace.
Right. And Dave said something very important earlier. He said trust. And the problem is that there is a lack of trust out there. That if you're trying to move from the current system to a very different system, and you got to have the purchasers and the providers trust each other. And if everybody thinks that somebody else is a villain, right, and they've been trying to screw me for years, and now I'm going to get them back through this process, right, nobody is going to feel comfortable going to something that is, while I think, absolutely, I agree with Steve, we can get there, but it's a scary thing, and that transition could be rocky, and you want to be able to feel like as if you're going into that in a way that you're not going to lose your shirt. So if you're a physician and you're trying to pay off your debt and you're trying to keep your practice alive, and somebody tells you, you're going to go, we want you to go at risk, right? You get worried about that. If you're a hospital who everybody wants to make sure that the ER is always there and the trauma team's ready to go and that the cath lab's ready to go, but nobody pays them for that, and you say, guess what, take some risk, and maybe you won't have enough money to cover that, then you have to worry about that. So we got to go into things together, and get past all of the old, who was trying to do something to me last year.
Dave, how do you do that? How do you build trust?
Well, I think we've been trying to bring the groups together. We've actually been working with ex-administration individuals from healthcare, the Levitt Group, actually trying to bring folks together and sit in one room and talk. From a McKesson point of view, we've actually run a lot of user groups where we actually put both sides of the house in the same room and have them openly discuss their problems. And we're actually seeing that now start to really bear some fruit. But going back to a couple of earlier comments that were made earlier, I think we sometimes think, Steve made the comment, this is a very complex problem. And we need to look at going by inch versus by mile. When we talk about price and price transparency, Blue Cross Blue Shield doesn't have one price for all employers. Each employer determines their own price and what services are covered. Just because it's a CPT code doesn't mean it's a covered service. So within McKesson, not every cholesterol test is covered, even though there's a valid CPT test, because of the relationship of the price. So there's not a secret playbook of pricing because it's a valid CPT. So each physician has their own pricing mechanism. So in total, we have to get transparency needs to be publish the price by the employer, not by the payer. Because I think that's the missing link there. You have to have it by the employer plan. Let every one of us see it from an employer point of view.
Do you guys agree with that?
For 60% of the commercially insured population in this country, the insurer is the employer. 60% of employees who have employer-sponsored insurance are covered by a self-insured employer. It is the employer who is actually at risk. And those employers actually don't understand how the healthcare system works. One of the things I do is I bring together employers and physicians and hospitals and around the country. And for example, one of the simple problems that we have in the healthcare system today is nobody pays a primary care doctor for a phone call. Even though the simplest way to resolve a patient's problems in many cases is for them to talk to the doctor on the phone and say, what should I do about this? Employers don't know that. I've had employers in the room with doctors saying, I had no idea you didn't get paid for a phone call. You should get paid for a phone call, right?
Oh, come on,
so
Harold.
what?
Oh,
Are you kidding me?
No, I'm not kidding you. We've actually
Well,
had
but we
employers,
just said that you don't wanna parse out
I'm
individual
telling you,
things that they
Leah, I
do.
can introduce you to the employers who said, I had no idea.
Why should an employer have to pay for a physician to make a phone call with a patient?
how does that work with payment?
Because if
reform,
it
this
keeps them
idea?
out of the emergency room.
I
see-
should be sitting down in between the two of them. And
There's-
help,
Are you kidding
maybe,
me?
See, that's the
They
idea.
should be
So
paid
why
for
should an
Steve and I are
employer
doing
pay
okay.
for a
Yeah,
phone
we're
call?
good over
right?
here.
They should be, you've made the point.
Why should the employer pay them for anything then,
They
Leah?
should be paid for the outcomes of what they achieve.
Isn't
for
that-
the
Absolutely
Isn't
patient.
that the idea of
They
And
payment
that's the
care.
point.
Not for the
Today we say
inputs,
we'll
which is what
pay
a
you
phone
for a
call is.
15-minute visit in the office. We won't pay you for a phone call. What we should do is pay you to take care of the patient.
Well, let me-
and
let
have
me-
you have the
Okay.
flexibility to do whatever it is that that patient needs.
Doesn't this get to the difficulty of payment reform? This idea that it's not procedures, but the cost of dealing with knee pain could be shared by multiple providers, have multiple procedures sort of necessary for it. You want to start paying for phone calls? I mean,
No. I don't want to pay for phone calls. I want to actually pay to manage the patient's condition. But the problem is today we don't pay a doctor to manage the patient's condition. We pay them for an office visit. And so if, in fact, the doctor can actually keep you healthy enough and not have to have you come into the office, they will lose money because of that today.
I'm gonna-
That's the way we pay today.
tag on to that. And again, value-based reimbursement is happening today. And most physicians and hospitals actually today are paid by value. I mean, the 2 midnight rule that everyone in this room lives by is a step on value-based. There's here in Boston, Boston's Children's pays for asthma patients for their children for bed linens and to help reduce the amount of readmissions. In Arizona, we're seeing, due to their temperature and climate, hospitals actually buying air conditioners to give to their patients to reduce their readmission rates, to overcome that 2 midnight rule. And so we're seeing value-based reimbursement happen. We're just not seeing it move at the pace that we want it to happen, and we don't know how to judge quality. So back to Leah, and it's there's no food restaurant A, B, or C thing sitting on the front door, and there's no simple checklist of what is quality. And socially, when I go to the physician, I want the best care I can get, and we don't pay for our services up front. We pay for it on the back end. So do I have enough money to pay for it? I don't care. Until we start changing that whole process, which is a very difficult problem, a social contract, how do we do that? Because if it's my kid, I don't really care.
I'm a little confused now, though. Price information doesn't work on its own. We need quality information. Quality information is, you're saying, very, very difficult to actually measure. We don't know how to do it properly. So then what's the point of price transparency?
Well,
I feel like we're running around in circles here.
We do know how to do it to some extent. I mean, we're in the...
How do we do it?
Well, let me give you an example of an area where we're very focused and where there is some pretty good research on the measures, and that's around patient safety. And that's a big part of Obamacare as well. And that's an area where we're very concerned about what pricing really costs to employers. In the time that this session takes, 15 people are going to die of a preventable medical error in a hospital in this country. It's a population estimated maybe, give or take a few 100,000. A population the size of Miami will die every year from a preventable medical error in a hospital. And we actually do have some pretty good measures now to look at how well hospitals are doing. Some are good, and some aren't so good at preventing those. Employers pay for those. Those are not costs borne necessarily by the hospital in most cases. In most cases, those are passed on, and there's good literature on this, that are passed on to the employers. In our estimation, Leapfrog's done a calculator applying that literature and finds that employers pay somewhere around $7,000 for every one of their employees admitted to a hospital. Not just the ones that get harmed, but every one, they're paying a surcharge of $7,000 to pay for those errors. So that's a price they're paying for which the value is zero or negative value. And so in the area of healthcare, the need for employers to come together with with providers is interesting. But I also think that they need to exert a market push. And pushes sometimes are not comfortable, and they aren't going to be kumbaya conversations. They're going to be tough conversations about saying, I'm had it with the problems that my employees are encountering and paying for those problems. It's time for you to come back into the market and give me a better service for my employees. That simple market conversation that we see in every other industry doesn't happen as much in healthcare, and I think that's what's needed.
And what they need to do is that the provider needs to offer a warranty on the care so that in fact they can actually do better financially, not just get more patients, which is not what you necessarily want, more people going to the hospital. What you want to do is to have the provider be able to do better financially by having higher quality, and we don't have that. Now the problem with employers is that employers aren't actually changing health plans today to pick a health plan that will actually pay differently. They're sticking with the same health plans and they're saying it's the provider's problem, which is the villain issue. What they have to do is come together and say we need a different way to pay. We employers will pay differently if you'll accept a different way to pay that will actually give us better value.
So I agree with that, and it's good to say at a high level. But since we're in Boston, I'll quote a Boston politician. That is, all politics is local, well, all healthcare is local. And how healthcare is delivered, here in Boston versus rural Montana is a little bit different. And if you think the same exact solution is going to span that, one size fits all, I think you'll be disappointed. And on the other hand, we can't have 1,000 one-offs either. And so what is that group of approaches to reimbursement? That toolbox, more than 3, less than 10, that you can bring into a market, that you can take a look at the capabilities of that market today. Do they even have an electronic infrastructure? What is the characteristics of the providers in that market? And then try to match the right set of tools for alignment, for quality measurement towards a accepted set of quality standards that they're capable of doing to get them on this pathway to this place that we all want to go. And it's not going to be the same road, but we want them all heading to the same direction. Let's provide those tools not to the consumer and to the providers of care to help them get on that pathway. And it can't be a one-size-fits-all. And so it's going to be that series of approaches that I think is going to be how we can get to aligned reimbursement, to working together for better quality measures on both institution levels, but also treatment specific.
I agree with Steve, and I heard earlier there were a lot of physicians in the room, and a simple question is, does anyone go to work trying to provide bad care? I mean, each physician that I know goes and tries to take care of the patient the best that they can. But what we're trying to do now is provide them with clinical information so that they can provide better care. And that's trying to be aggregated across the industry so that the physicians have the right tools. Physicians are extremely, scientific in the way they approach each of us. Each of us up here react differently to different drugs. And so we can't think it's, back to one shoe fits us all. We're all individual. And so with that, I think it's important that we come to that 3 to 10. So we're really agreeing on this end. And I think we can bring the payers and the providers together, but we want to make it where the information is standard and people can make meaningful decisions. Okay. Back to Leah's trying to do from a quality. Take quality, make it unified, and publish it. And let's just publish it. All right, we'll work through it, but the problem is no one wants to be on the bottom of the list, okay? And so we just have to finally find a way to get enough momentum and push it over and put the ones, because after we do that, we'll then raise the bar.
Let me
Agreed.
open this up to the audience for questions. In the back there. Yeah. Can we get the other mic, perhaps?
It's transparent.
Okay, cool. My name's Jonah Comstock. I'm with Moby Health News. I had a question for Leah. When you were talking about the poll, you said there's no group of people that just looks at cost in healthcare and doesn't look at quality at all. And I think by and large, that's a good point, but I think the group of people that does look at cost and not quality is the same group of people that buys the cheapest car without looking at the quality and the cheapest brand of bread without looking at the quality. And it's people who just don't have very much money. And so, I think the meaning of the question in the poll is price transparency going to hurt the care quality for the poor?
I think the opportunity that we have to be thinking about is that we shouldn't be, in the long run, we're not just comparing the prices of things today. What we want to be able to move towards is very different ways of delivering care that actually deliver care to people at lower costs. The issue is not just how safe are they once they're in the hospital, but did they need to be in the hospital at all in the first place? And could we have actually been able to keep them healthier in a way that they didn't need to be there? And that requires a much more upfront investment and a longer term time horizon. And today we have very short time horizons in healthcare. People switch health plans every year, trying to get a lower premium, but that also creates no real incentive to be able to invest in things today that will help keep people healthier in the long run. So ultimately, that's one of the reasons why we're spending so much today, is because it is all about people who have delayed care and ended up with much more expensive conditions than they would have otherwise. And then what you don't want to do is to say, okay, you've avoided colonoscopies and now you have, metastatic colon cancer. Where's the cheapest place to go and get your care? What you want to say is, so how can we get you better care up front so you don't even have to face that kind of a choice?
But to answer your question, I by the way, agree with Harold on that ideally we would have a system where we pay so-called bundled payments, where we pay for the overall treatment and providers are held accountable for how well they do in caring for those patients, not for the individual services. But given what we have and the loaves of bread that we have to sell in the shelves of virtual hospitals, so to speak, it is true that pricing is a market phenomenon, and as a result there are winners and losers in markets, and losers often are poor people who can least afford to lose. So there's no question it's not perfect. But having said that, even low-income people, and sometimes more so than high-income people, shop for the best they can get for the few dollars they have. So even for bread, I'm certain that low-income people actually do care about what they're getting. They don't want stale bread. They don't like whole wheat. They are looking for a particular product, and they have a right to look for that. And the fact that you have a market of consumers shopping that way, considering the quality of services they can get provided to them and what that pricing is, will improve overall quality and cost effectiveness in our system. We know that works. There are winners and losers, though, so we're going to have to watch that carefully as a phenomenon and think about it from a policy perspective. So I don't mean to oversimplify it, but just because some people can't necessarily afford everything in the healthcare system doesn't mean that we abandon it, the idea of pricing and market phenomenon as something that can be applied to the healthcare system.
Go ahead, Dave.
We have a tool that we sell that estimates will a patient pay their bill or not. And that's not a plug on the tool, but it's a plug on the question. And that is, what we actually see is high-income individuals don't pay their bills at a greater percentage than individuals at a low income. And it's just because you're receiving care after you pay your bills afterwards. It's the last bill that goes into the stack. So the car, the $50,000 car, etc. That bill is the last thing that hits the stack. And so a lot of times it's, until you get your third EOB, you don't pay your bill. And that's how I do my own bills at home. Okay, I mean, I don't pay it up front. I wait till I get my third one to make sure everybody else paid before I did. And so with that, but a lot of the individuals that don't have the financial wherewithal or understand the system, as soon as they get that first bill, they're paying. They may not have the ability, but they're making some type of payment against the minimum. And so don't think of price transparency as impacting access. I think once we build the two, I think it will actually make it a better scenario with quality and that price, and we'll be able to go from there. So sorry.
Thanks. And let me talk about another way that the Affordable Care Act has changed our industry. And that is, historically, the insurance industry has been made up, who we cover, largely people, the PLM, people like me, right? Employed by a company, provided health care by the company. But by bringing in access to health insurance to larger numbers of people, we're seeing a great deal more diversity of incomes. And so those tools on value become increasingly important because the price sensitivity, as you move into lower income groups that historically have been disadvantaged on access to health care and health insurance, that price sensitivity is something that's very important to them. And so these value tools are critically important, and now they're newly important to us because these are our members. These are the people that we insure, and that's a good thing. Those are people that always should have been insured and just haven't been. And because we are now covering increasing numbers, those disadvantaged groups of people that economically or because of employment didn't have access to health insurance, it becomes very relevant to our world, and we're happy that it is.